and set of struggles. In some countries have lots of available vaccine, but they're not able to get people to take the vaccine. And there are other countries, many in the south, who are desperate to get vaccine and who can't get access to it. So we have, each country is now dealing with almost unique scenarios regarding how they've dealt with the pandemic up to now, what their vaccination level is, what the level of buy-in there is from communities around public health measures, how much support there is for communities to continue those measures. And I don't know right now around the world 2 countries that are implementing exactly the same policies or in exactly the same epidemiologic situation. So I think it's time that we recommit ourselves to really now, especially in the Northern Hemisphere heading into the winter, it's going to have to be a serious look at how we can increase vaccination levels and at the same time maintain some of the measures. And I see increasingly that governments, and I understand that, they're handing back that choice to people and saying, well, we're shutting down the emergency response mechanisms and now we expect that individuals will take on managing the risks themselves. And maybe that's true in some countries with very high rates of vaccination, but it's not the case in most countries. So I'm a little concerned that some countries are sort of saying this is all over, and there's nothing more to worry about. And I don't want to be a pessimist in that. For them, I do hope it's all over, but all of the indications are that this virus still has a lot of kinetic energy, it has a lot of momentum still, and it will move and it will pick off those people who are not protected with vaccine. And if that happens to be a young, healthy person, then maybe that isn't of a great consequence, but long COVID is showing that it may be. But also that will tend to potentially produce virus that may reinfect people who are not protected, particularly those with immunologic suppression or with who are very elderly, or people who haven't been exposed at all yet or haven't been vaccinated could be infected. So I'm really pleased that we're seeing increased vaccine rollout and increased vaccine uptake, but I'm really concerned that it's still very, very inequitous. And we're still seeing doctors and nurses going to work today around the world in COVID wards who have not got vaccinated. I mean, that's incredible. That's really incredible.
Thank you very much, Mike. Here's already a question from Carrie Boyle Samuelson, watching us on Facebook. What do we know about the treatment, and are we doing enough to develop new treatments, like we are investing in vaccines? As she's saying that early treatment is very important.
Well, there's a lot of work going on therapeutics. Part of the slowdown on therapeutics has been those variants that have emerged have escaped the effectiveness of some of the original monoclonal antibodies or polyclonal antibodies, which means we have to stay one step ahead of the virus. And that's why doing variant surveillance and keeping an eye on the genetic diversity of the virus is so important, because some of these therapies are very, very specifically designed for a specific strain of the virus, and therefore we have to be very much ahead. Now we are seeing new second generation monoclonal and polyclonal antibodies coming on stream that will deal with variant strains, but they're expensive and they're not very available. We are seeing, for example, dexamethasone and IL-6 inhibitors, which modify the immune response, being used. Dexamethasone is used widely, but IL-6 inhibitors are expensive. They provide an additional benefit, but they're, again, no more than with the vaccines. There are a very small number of producers, and most of those doses have been sold to the wealthy countries. And we're struggling to access doses of IL-6 inhibitors. I believe, Maria, and that's another inequity. Okay, it's not as glaring and it's not as obvious and it's not as public as the vaccine one, but once again we repeat the same inequities. It doesn't matter at the large scale or at the small scale. The developed world and the industrialized world just doesn't seem to get it. It really doesn't. It talks, the rhetoric is fine, it's all about sharing, it's all about fairness, but in reality, when push comes to shove and these products are available, they are hoarded in countries and they're not shared. Dr. Tedros has said this again and again and again, and maybe if we keep saying it often enough, that we'll eventually come around to understanding that that's the reality. And there's a huge gap between the rhetoric and the reality right now, and that's the same for therapeutics. There is a lot of work going on as well, upstream research on small molecules, and other stuff to try and develop longer term therapies, antivirals, and there is some hopeful news and there are some interesting products there, but none of them are even close to being at the level of being able to be deployed or used at population level, and there's some interesting and exciting clinical trials underway at the moment, and we hope that will lead to cheap and effective therapies, and that is certainly one of the big targets. But again, the barriers there are to ensure that whatever therapies we develop are safe, they're effective, and more importantly, available to those who need them. And we seem to be doing well on developing the countermeasures safe and effective. We seem to be failing on the fairness bit every time. So if we do, and I hope we do, Maria may speak to that, come up with newer therapies, and I mean we in the royal we, WHO in itself is not doing this research. This is done by many academic institutes, scientific research institute, public and private sector organizations all over the world. There's a huge push on this, and that's been funded by many different funding partners, WHO, I think the Wellcome Trust, the Bill and Melinda Gates Foundation, and many others. The Glopidar grouping, which is a grouping of donors that's specifically focused on funding upstream research. They've been very active in funding this research. I know the NIH and others in the US have been funding that. So there's a tremendous investment going into this, and it's public money or it's philanthropic money going into driving these innovations. We're not there yet. We don't have cheap, effective antivirals available. Dexamethasone is not an antiviral. It's an anti-inflammatory, and it does save lives. But we don't have the equivalent drug that kills the virus. And that's what we're missing. And we're missing the same in many other viral diseases. The monoclonal and polyclonal antibodies provide great hope, but they're harder to use when the virus is evolving so quickly, which means that's why we still have to focus on keeping transmission down and stopping the variants emerging, because it's that emergence of variants that reduces the impact of our therapeutics.
Can I just also comment on that? So the inequity and the lack of access, it's the vaccines, it's the therapeutics, it's also the diagnostics, it's also the PPE. We're seeing over and over and over again, it is hoarding. It is the hoarding of these materials. We saw it in the beginning of the pandemic with PPE. But this is not just unfair, it's not just immoral, it's prolonging the pandemic, and it is resulting in people dying. And I think we need to be blunt. I think we need to be very clear that this is prolonging the pandemic. We have tools, we have enough vaccine around the world. If we had used the vaccine doses that were available differently, we would be in a very different situation right now globally. But it's the same thing with PPE. It's the same thing with the therapeutics. And we all need to be held accountable for this. Those who are manufacturing, those who are selling, those who are buying, everyone has a role to play. You hear me say everyone has a role to play, and I usually mean it at an individual level about what you can do to keep yourself safe. But this also applies across products. And it's not just sending something, to a country. It's the use of that, getting that, the vaccine into someone's arm. It's using that test appropriately, having that test come back with results quicker so that it can actually link to public health action. It's prolonging the pandemic. And the sharing of these doses is not charity. That's the other misconception I think that's out there, that it's just, about charity. We are completely in this together, whether or not people recognize that or not. But if you achieve a certain level of vaccination, for example, because of these virus variants, no one is safe until everyone is safe because the virus is evolving. So there's almost a false sense of security that if you reach this magical number, this magical percentage, and of course we want more people vaccinated. I'm definitely advocating for more vaccination, but it has to be shared around the world, because you won't be safe if just your population. Just look around, we're in the summer in the Northern Hemisphere. You just look around at how people are traveling. This will have an impact in the next weeks. It's already having an impact on transmission. Our actions, whether we're talking about products, whether we're talking about wearing a mask, have consequences. So these are things that we need to address in trying to end this pandemic. And the sharing of this, the development of these products is part of that.
And just one point I forgot to mention, Anna Maria and others
Yeah.
will kill me if I don't. A lot of the work on therapeutics too, it's really, really important, because we've heard lots of anecdotes over the last 2 years about this drug works and that drug works, and people making observations, sometimes very rational observations, small trials that have interesting results. We really do need to on doing large-scale, multi-centre clinical trials, and there are lots of good examples of that around the world. The platform WHO has developed is called the Solidarity Platform. We've did the first phase of that. Now we've started the Solidarity Plus trials with 3 new drugs in it. That's the way for us to get results quickly, where we do multiple trials, well controlled across a range of countries with everyone participating in the process, which allows us to get the quickest results in terms of getting good data to show whether a drug is effective or not. And you've seen, I think everyone out there will have noticed during the pandemic, how many controversies have we had because someone says this drug works, this drug, and in the end, when you do a large-scale trial, what's shown is those drugs are not effective one way or the other, and we can't prove how effective they are. So it's not just in developing the therapeutics we need to do, but we need to be much better at doing these, multi-country trials, where we work together in solidarity to share the data so we can quickly get results. This isn't a competition. And sometimes this is seen as competition between the developed world and the developing world. And in a crisis like this, we can't afford to destructively compete on who has the best trial or who has the best study. We need to bring all of that data together, and that's WHO's role, and the role of the R&D blueprint for epidemics, which we've been running now for a number of years, is to create that sort of community of practice around the world who work together to define what the priorities are for research, to design the platforms that we need, and then to work together. We're doing that with vaccines now as well, with the Solidarity vaccine trials. So that's where I think WHO has its added value in not doing the actual research. We don't go out there and actually physically do this research. What we do is create this level playing field, this sort of, and democratize and allow everyone to contribute what they're doing and standardize that and make that available to everyone. So you working in one country can trust the data from another country because you know it's been collected in a very specific way. So I think it's important too, as we look further for new drugs and new therapeutics, that we also focus on how we're going to test them and then how we're going to make sure they're available to everybody.
Thank you so much. We have a few questions, follow-up questions on research, but many questions about variants are coming, so I will need to take those as well. Just while we are talking about treatments, here is the first one from a viewer on LinkedIn. Do you recommend monoclonal antibodies to all new cases of COVID-19?
I think it depends which ones you're talking about, because there's been different versions of monoclonal, polyclonal antibodies available. I think we're back to this idea of finding the drug that works for that particular variant, because what we've seen is with variants, they escape therapeutic sort of intervention. In a sense, what we've seen with vaccines is that the vaccines still remain effective against many variants. However, with polyclonal and monoclonal antibodies, at least the first generation of them, they're not as effective against the variants, so we lose them quickly. But there's a new generation of those coming out now, and yes, we should be using those as much as we can. But the problem again is there's limited availability, there's limited production capacity, and that production capacity and that availability is mainly in industrialized countries. So again, the scale of the problem outweighs the supply. Are we going to be able to scale up production of these products in a way that we can share with everybody? And again, we're back to the same issue that we spoke about with vaccines. Unless we commit to the idea of scaled up production and scaled up distribution, then we're never going to get there, because the rich will always be able to buy a limited supply. And that's just the reality, and you can't put too fine a point on this. What we really need is those drugs made available for the people most likely to benefit from those, and those are people, in hospitalized situations who can benefit from these life-saving interventions. And we're just not doing that effectively enough. But I have great hopes. I think that whole platform of monoclonal antibodies as a way of developing rapid therapies is really, really promising. But we've seen how fleeting that promise can be, because if we let the virus mutate, the virus escapes our therapeutic interventions. So yes, it's a bit like mRNA vaccines. Monoclonal antibodies have become a real, when I look back at my career 25 years ago, none of this existed. We dealt with Ebola and other things. We had no therapeutics, we had no vaccines. And to be in a situation where we're developing them within 12 months, deploying them within 12 months of the emergence of a brand new disease is groundbreaking. Now, I think we can get better and we can get faster at that, and I think we will. Where we've fallen down is in scale up and in equitable distribution. What we've done is done amazing things in innovation, and then we've failed in fairness. And that's counterproductive, because now we're letting transmission go on in countries and we're not stopping it using the exactly. So it's a kind of a self-fulfilling prophecy. But I don't want people to go away from a Facebook Live thinking, oh, well, it's terrible, everything is doomed. No, it's been human ingenuity and the commitment of scientists and others around the world who've put all this together is incredible. We're in a massive phase of human innovation. We see the same thing on the climate front. We're all very unjustifiably concerned by climate change and climate threat, and yet we see some of the solutions that are coming through. And I think we got to bet on human ingenuity, we got to bet on human creativity, but also we need to bet on fairness, human fairness, and the idea that we're willing to share the responsibility to fix things and the response and the products that are needed to fix things. I'm a bit worried because we're not doing it in this pandemic. We simply are not doing it, you know.
Can I just comment on the treatment questions are very specific. We have guidelines about the treatments that come out about, which drugs for which patients and when, but it's really about the right patient, the right dose at the right time. And that's really critical. So whatever therapeutic comes down the pipeline, it's about the right patient, the right dose, the right time, and being provided by a trained medical professional. We mentioned earlier that we're seeing a reduction in death in many places, but that's due to a number of factors. The vaccine is one. Those who are lucky enough to have the vaccine and have the full course of the vaccine, of the 1 or 2 doses, we are seeing a reduction in hospitalizations and we're seeing a reduction in deaths. But we're also seeing a reduction because patients are receiving earlier care. They're receiving care by experienced medical professionals because they've had 20 months of dealing with COVID-19, and so they have much more experience with that. And if we get better at, finding cases earlier or even preventing them in the first place, the healthcare system doesn't get overwhelmed. So medical professionals have more time with those patients. So it's the experience and then on top of that, having some therapeutics that are working to save lives. So that combination of factors, we're in a much better position to be able to save more people's lives. It all starts with prevention, but we are at a point now in this pandemic where we can actually take away the severe disease and death. But you have to have access to those tools. We cannot do that without having the access to those tools. And I think, when people say to us, how much longer, what do you expect? You don't get a short answer from us because it's dependent on all of those factors. But right now, we be very clear. We have the tools at hand that can remove severe disease and death. We need to use them. We need to develop more. We need to share them.
Thank you, Maria. There are 2 more research-related questions. One is from Kelly, watching us also on LinkedIn. For those who have had the new variant, been infected with the new variant, could giving blood help research define antibodies?
Yeah, that's how polyclonal, monoclonal antibodies are developed. People donate their blood, and it's how they, literally when you say clonal, what they do is essentially clone the antibodies from your blood. So there are probably very few people who've donated blood in that situation specifically result in huge numbers of people being ultimately treated. But it should be, again, done through the proper process. Yes. And there are, you can look it up online and see which researchers may be looking for donated blood. And it's not pints and pints of blood, don't get me wrong. It's usually a fairly small sample of blood. They won't bleed you dry. But it can be extremely helpful if people step forward. But to do it obviously in response to requests from, usually people doing this kind of research will advertise and will ask for volunteers to do that. And more power to people who are willing to do that. You're really helping research and helping your fellow persons.
It's a great question.
Yeah.
It's a really great question.
Thank you. Maria, maybe you can take this one. It's from Lauren, watching us on LinkedIn. What progress has been made in determining why some people who contract COVID get very sick and some people have no symptoms at all?
Oh, that's a fantastic question, Lauren, and probably we could speak to you for the next 3 hours about that, but I know we don't have time. We do know that, there are some clear things that we know of individuals who are more at a higher risk of developing severe disease. So people who are of an older age, above the age of 60, above the age of 70, above the age of 80, there's a higher risk of developing severe disease as your age increases. We also know that certain underlying conditions, medical conditions that you have before COVID, puts you at an increased risk of developing severe disease. Things like underlying heart disease or respiratory disease, obesity, diabetes, HIV. These are some factors that would put you at an increased risk of developing severe disease. So we're studying this all the time. I mean, there are certain biomarkers, certain genetic factors, a lot of research in this area that is looking at that. But in general, we know advanced age and medical conditions will put you at an increased risk. Again, which is why it's so important that it starts with prevention as much as we can to prevent getting infected. And you'll see that there are certain recommendations that will be for if you're older, wear a medical mask as opposed to a fabric mask, for example, or, that's why, vaccination starts. The priority groups are older age groups, people with underlying conditions, and of course our frontline workers. Mm-hmm. It's a good question.
And we've seen different patterns in previous pandemics. I mean, not all infectious diseases affect all age groups in the same way. So when we see classic winter pneumonia or influenza, it very often badly affects very old persons, but also very, very young persons. We don't see that same impact in SARS-CoV-2 or in COVID-19. We saw in the pandemic of 1919, the very young and the very old affected, where we had this huge peak of mortality in the middle-aged and the kind of healthy young people. And that's what really caused the impact of the 1918-1919 pandemic, was so many young people. Now, the question at that time was asked, is that because they're more affected, or is that because there were so many young men packed into getting ready to go to war, military camps, and they were stressed out and they were poorly nourished and and therefore the virus just managed to have much more impact in that group? I don't think anyone is completely sure. But I think, in terms of how you get sick from a virus, you either get sick from the virus itself or you get sick from your response to the virus. Yeah. And we see this in Ebola, we see it in many emerging diseases. Very often it's not the direct impact of the virus. The virus infects you, and you very often get a strong fever and you get all the symptoms. And then there's a second phase, and for most young healthy people, they recover. They don't have that second phase. They might have symptoms for a few weeks, they mightn't feel so good, but they slowly recover. For some other people, for a small group of people, and usually it's people who are elderly, people with underlying conditions, and some younger people, you get this immunologically mediated response. You get an inflammatory response where you start to get inflammation, particularly in the lungs or in the cardiovascular system, which is essentially becomes much worse if you've got underlying hypertensive or tension or cardiac disease or respiratory disease. You can't tolerate that. And what happens is people can't transfer oxygen from their blood, from their lungs into the blood anymore. So it's not the virus, it's your own immune system has gone into overdrive. And it's called an immunologically mediated damage. And I've been very technical here, but that's why things like dexamethasone work, because they reduce the inflammation. They stop that secondary effect. So when we talk about therapeutics, we want something to kill the virus, or we want something to stop the abnormal response to the presence of the virus. And therefore, whether the virus infects you or not depends on the dose that you're exposed to. It depends on the route of exposure. It can depend on so many other factors. But Maria's right. In terms of the outcome and how severely ill you get, the primary things that determine that have been your age and the presence of underlying conditions. We saw that in long-term care facilities with our older populations, and how tragic it's been all over the world for that. But again, to caution people, that doesn't mean that all infections in younger people are not severe. There are many severe, and we've seen the average age of admission to ICU drop, and we also see long COVID has emerged, and people who are suffering extended long-term symptoms. And I think we're now working towards more well-defined definitions in the coming days, and maybe you could speak to that, because I think it's important that young people don't assume that we've just said it's only old people and young people are in the clear. Yes, in the main, younger people who get this disease get sick or don't get sick and recover completely. But there is a small but significant minority of people who have long-term COVID symptoms, and they need to be studied very carefully so we can find ways to get them out of that over time.
So there's a lot of work around this post-COVID condition or long COVID. I believe we'll be issuing a case definition next week. I think that's the intended publication of that. But there's a lot of work that we've been doing with partners, with many different specialists, because this post-COVID condition, this long COVID, affects many organs of the body. And we are still, even though we're 20 months into it, and even though we know that this is real, it is real, we're trying to define it. And it's so difficult to define because it has so many different types of symptoms. And essentially, it's after you get over that first acute phase, that acute disease, there's a lot of lingering symptoms. It could be as simple as, not as simple as, it could be as clear as not having any taste or smell for a certain amount of time. It could be what people call brain fog. Some people who are very healthy athletes, running marathons, are having a hard time walking upstairs. There's a lot of different factors. There's cardiac conditions. There's a lot of different factors that we are working with to study. We've been establishing these cohort studies with groups around the world to better understand what it is, so that there's not only recognition, but that there's proper research so that we can develop proper rehab. So this is something that we continue to work on. I know we have a lot of people that are following us on this. This is something we think about and we work on every single day. So please don't lose hope for those of you who are suffering from long COVID. We hear you. We want to continue to work with you and to make sure that we really advance this, because you will not be forgotten in this. It's, there are so many different aspects to this. And when I hear people say, young people, they don't have to worry about it because it doesn't cause such severe disease in them. Well, the long COVID and post-COVID condition, we have to think about this. Again, it's about prevention as much as we can. And there's a lot that we can do that we just have to continue to focus on that.
Thank you, Maria. Oh, Mike, sorry.
No.
Okay, I thought maybe you want to add something.
Approval.
Several questions are coming around variants.
Okay.
So maybe first one is to give an update about the Delta variant. Do we have any news, any new knowledge, or what's the latest on Delta and its effects around the world?
So, we, again, looking at the changes in the virus, the Delta variant is the latest variant of concern that WHO is tracking at a global level. There are 4 variants of concern that we're tracking at a global level. The Delta variant one is predominant. Where Delta takes hold, where this variant takes hold, it really quickly, rapidly replaces other viruses that are circulating. And that's important because, when we're tracking this, we need to better have good testing, we need good sequencing around the world to be able to detect which variant is circulating. But, essentially, I'm looking at a figure, we were giving a presentation this morning. The predominance of the sequences that are shared on platforms like GISAID is the Delta variant. But Delta is also continuing to evolve. So we're looking at several sublineages of Delta and looking at how the virus may be changing. We expect the virus to continue to change. Delta will not be the last variant that you will hear us talk about. There are 5 variants of interest that we are also tracking at a global level. The latest one has been designated as mu, the Greek letter mu. This is the B1621. It was first identified and reported from Colombia. And the reason it's been designated as a variant of interest, it was designated on the 30th of August, is because in some countries, the proportion of cases with the mu variant is increasing. Having said that, and that's in South America, but in other countries, the proportion of mu is decreasing. Where Delta takes over really quickly. And we look at some of the mutations that are part of mu that have some worry in terms of reduced neutralization. So there's, it's something that we're constantly tracking.
When you say reduced neutralization, what do you mean by that?
It's coming from some studies. And so what we are looking at when we evaluate a variant or a mutation are several things. One is transmission. Is transmission increasing? 2, does it cause more severe disease or a change in the disease presentation? Maybe many more are hospitalized or have need or will die if they're infected with that variant. We look at if our diagnostics work. Can we still find people who have infection, that have that virus. We look at the therapeutics, and if there's a reduction in the effectiveness of the therapeutics, and the same thing with vaccination. And the way that we study the body's response to that either comes from lab studies, where we're looking at this antibody response, and then we also do this in humans if the virus is circulating in humans. So in the mu variant, there are some studies that in the mutations that have been identified to suggest that it may have. Now, I say that, but the virus also still needs to circulate. So you may have also heard of this variant called C.1.2. And this was a variant that was reported from South Africa in May. And there was a preprint study that came out showing some research on this. And there were some worrying signs within that research itself. But that virus, that variant, that C.1.2, is not actually circulating. It's not actually taking off. And so we don't only look at what the mutations mean and how they impact transmission, severity, therapeutics, diagnostics, vaccines, but also, is it circulating? And right now, the Delta variant is really predominant. Yeah.
Okay, looking into those criteria that you mentioned, and several of our viewers asked, including Laura Michelle from watching us on Facebook, how serious a threat is the mu variant?
Well, all of the viruses are a serious threat. And so, as a general public, for the general public, the same concern that you have about any virus that is circulating, it doesn't matter what that variant is. I think the Delta variant for me is the one that's most concerning because of the increased transmissibility. It's doubly transmissible compared to the ancestral strain, which means that it can spread to more people. Our countermeasures still work. The public health and social measures still work, the vaccines still work against severe disease and death, so we have to continue to use those. But from a general public point of view, you should be concerned if the virus is circulating. And right now, the virus is circulating in too many locations, and it's circulating at a high level in too many locations. So I think what is good for, and it's a good question, so I don't want to dismiss the question by any means, but what we are trying to do as the World Health Organization is to bring people together to have those discussions. So that preprint I mentioned on the C.1.2, actually our researchers were aware of that before the paper came out online. And that's what I hope the public wants to hear from us, that we are following it, that we have the right collaborations in place. The mu variant is of concern, it's of interest. I mean, they're all of concern, I think it's, but it's of interest to us because of the combination of mutations that it has. But it doesn't seem to be circulating.
Mm-hmm. And remember, these viruses, in some senses, are competing with each other, not just with us.
Right.
Any virus that emerges has got to be able to compete with the best of class. And at the moment, the best of class in terms of transmission is the Delta variant. So it tends to outcompete other variants. So we may have the emergence, like, for example, the mu variant does contain genotypic or sequences and, sort of a structure that would indicate that it could be better at virus or vaccine escape or other things. But that won't matter if it can transmit efficiently. That won't matter if it can transmit efficiently. So I think that's the issue. So a virus becomes a variant of concern when it shows those kinds of changes that are worrying in terms of therapeutic escape, diagnostic escape or vaccine escape, and especially if it also shows signs that it can transmit more efficiently. And that's what Delta variant did, and that's what makes it so concerning or worrying. And like that, we will expect to see more. And I think that's the thing, and we thank our colleagues in GISAID, NextStrain, and all the different platforms that are publishing all of these data, and the people who are submitting to that, plus also the work we're doing ourselves directly with national authorities, to be able to maintain a really strong overview of what's going on day to day, hour by hour around the world, so we can build up a kind of a profile for each of these variants and characterize them properly. Because not every variant means the sky's going to fall in. Each variant needs to be looked at for its characteristics, in terms of its potential to cause more severe disease, its potential to transmit, its potential to escape vaccines. And we need to then get consensus amongst the scientific community that this variant needs to be monitored, it's of interest. If it's of concern, then we really need to start looking at diagnostics and how we develop better vaccines and evolve our countermeasures. And that's the whole process we've tried to put together, is to have a kind of, and I think the use of the the nomenclature and the to get away from country associations has helped, because now people talk about the Delta variant, the Mu variant. They're not talking about the country in which the variant emerged and all of the stigma that went with that. So I think we're in a rational period of discussion. We've got a great system now emerging globally around, and that next evolution in surveillance. You were talking about field epi earlier and the World Field Epidemiology Day, and greetings to all our colleagues out there in the epidemiology training programs around the world and in the Global Outbreak Alert and Response Network and GORN and everything else. But field epidemiology and public health has been revolutionized by genetic science, because our ability to track viruses and our ability to understand, have a deeper understanding of virus transmission, and then obviously for scientists and others to develop countermeasures, has been revolutionized by not just following variants, but our ability to track the genetic evolution of these viruses is incredible. And we wouldn't have had that. That would have been a huge, in SARS in 2003, it would take you days and days and days to get a single sequence, and it would be imperfect. And now we have this, at our fingertips technology. And again, WHO's job is to bring all that together, so it's not happening in 1,000 places and not connecting. And that's the power of platforms like GISAID and others, that they bring. We have an opportunity to share and pool our knowledge and our data, and then we can all look at that data together, and we can come up with a common understanding of how dangerous a variant is or not, or what we need to do in response to that or not. So I think we're really beginning to learn how to do this better, because I think sometimes when we're talking about the pandemic, we're always talking about what's going wrong, and to an extent that's important that we talk about the bits we're not doing well. But there are certain parts of this where we really have, and I mean again the collective we, mainly scientific colleagues out there in all the institutions, are really revolutionizing public health for the future. And if we learn the lessons of this pandemic, we'll be a lot better prepared for the next one.
So I need to give you an example, right? So we're talking about this variant, and we're talking about this tracking system. So everything about the cases being tested, the sequences being done, shared openly and publicly with platforms like GISAID. I'm on the GISAID website right now looking at Mu, because the question was, how worried should we be? We can actually track, in terms of the number of sequences that are shared, that it's tracing down, meaning that the proportion of those people who are infected with these variants for Mu is declining in the regions, in all of the regions right now around the world. The reason we have this as this variant of interest is because the combination of the variants, combination of the mutations, and the fact that it can circulate. So I think for me, I take quite some comfort, and I hope you do watching this as well, is that there are so many people that are studying this, that are working collaboratively together, and that are sharing this information. I want people to kind of hear this and be like, all right, they're on it. They may not have all of the information. We certainly don't get everything right all the time. We know that, but we have partnerships. We have trusted partnerships in place, and these platforms have been developed, they've been nurtured, and they're being used. And they're being used in real time. So I love that these questions are coming, but I think everybody needs to understand the virus that is circulating, whether it's Delta, whether it's Mu, whether it's whatever the next one may be, you still have control about keeping yourself safe. We have to keep coming back to this. Vaccines are part of the solution. They are not the only part of the solution. I've had several people come up to me recently and say, it would be really nice if we talked more about vaccines and not vaccines alone. And I wonder if they've ever heard me or you speak on this, because it's so critical. And if we have more voices out there about the vaccines and not vaccines alone, I think we can make a little bit of progress on that, because everybody should feel empowered that they have a role to play.
Thank you both. Before we close, I think there's one very important issue that we need to address, and we were receiving questions about schools reopening. We were talking about young people, variants, and how young people can be affected. So in this setting now, when the schools are reopening or starting a new traditional school here, what do decision makers need to know to ensure that it's safe for children and adolescents to go back to school? What do parents need to know, or what do kids and adolescents need to know?
I think we go back to the basics on this. There are many countries, there are many areas that have had schools open and have worked to prioritize opening up of schools. Schools operate in communities. So if you can control, first of all, if you can control transmission in those communities, people who work at those schools, people who attend those schools are safer. We know that having a plan in place, to be able to do surveillance, to be able to test, if somebody is symptomatic or having some signs, do some contact tracing, having good communication with the kids, with the teachers, with the work staff, with the parents. It's about having provisions in place within those schools about distancing, about wearing of masks, about making sure there's good disinfection and good ventilation. All of that still stands. There isn't anything necessarily new, but it's about making sure that you make the effort for those who are running those schools to make sure that you prioritize to do it as safely as possible. And individuals, it's about also what you do as parents, as children. It's about how much you mix with others. If you could, take care of yourself as well and try to minimize the amount of interactions you have with others, that also makes that school safe. And because parents and children also have a role to play in this as well. But we all recognize the importance of school, keeping schools open, because in many parts of the world schools have not opened at all. And this has had a massive detrimental impact on children and their families around the world. But combination of factors, combination of an approach to get those open.
Yeah, I think in situations where you've got reasonable control over the virus, then closing schools should be a last resort. I mean, there's lots of other stuff you can close, and there's lots of other things you can shut down. And there is a huge trade-off here in terms of the value of education for children. And the fact that school is very often a safe space for kids, sometimes the safest space they exist in. Sometimes it's a source of good nutrition. It's not just a place of education. So I think we have to focus on that. And governments need to support schools in making those extra investments, creating the extra space that's needed, having that ability to do the social and physical distancing, having in place the measures to do testing, having in place, plenty available masks if masks are the way to go if they can't do the physical distancing. So, and each school, I suppose, is unique in that. And I've seen some school principals and school boards do remarkable work. Yeah. Very creative. Yeah. Schools are creative places, but teachers and school boards need to be supported in doing that by the state. They need to be facilitated. They can't put barriers up. And I think that in some places, schools have felt sort of they've been left on their own a little. And it is a responsibility of the state to support schools. It's one thing having a policy, it's another thing turning that policy into practice. And policy into practice in most situations means resources. And you can't ask people to do more with less, although that's what they've been doing for a very, very long time. So, and it is important, where we have especially vulnerable teachers themselves. Many of them have continued to educate and teach despite the risk to themselves. And I think vaccinating those as frontline workers is also very important, so we can ensure that teachers can continue to teach. But we can most schools can be made pretty safe in terms of COVID transmission. But it's not an easy trade-off. But I think we have to look at schools in a sense as the last thing we close, in a society. There's a lot more we can control than that. And I think, with UNICEF and others, we've worked very closely on this. And our colleagues in UNICEF have done excellent work on schools, particularly in developing countries, to advise them on how to be able to stay open safely. So, we're very much aligned with our brothers and sisters in UNICEF around the importance of education, and that's a precious resource for any kid, particularly someone growing up in a developing country. And we have to do everything possible to keep schools open, because the loss of education is a lifelong loss. And it may be in the Western and northern countries that can be recovered, but that time lost in education in many countries can't be recovered. So we really have to. Now, there are situations with intense transmission where we've seen before, where we have ICUs full and hospitals overwhelmed, where society has to be effectively shut down. And that's perfectly justifiable in certain circumstances. But what we're saying now, in most situations, most transmission situations around the world, with the availability of vaccines and other countermeasures, we can find a solution for schools that allows schools to stay open safely while we're doing everything else. But it doesn't mean that we haven't got certain measures to still carry out in schools to make it safe. So I hope this fall, as kids go back to school, that we can keep kids in school this year.
Thank you both. And here is the last question that came from our Twitter viewer at the beginning of the conversation, but I felt maybe this is a good way to close today's session. What is the criteria for calling off the pandemic, and are we close to that point?
You wanted to end the session with that one.
No, there is no point where you call an end to a pandemic. In effect, if we think about the last pandemic in 2009 of influenza, the predominant strain still transmitting is the virus that caused the pandemic. So I fully expect that this virus will continue to transmit for a very long time. The question is whether it's still causing a public health emergency. And that is determined by how many people it's making severely ill, how many people that virus is killing, and to what extent we've controlled transmission. So from my perspective, if we can continue the rollout of vaccines in a more equitable way, if we can keep control on the variants, and we can get to very high herd immunity levels and good control measures, basically good control measures, then if we can bring the death, as Maria said in the beginning, and the hospitalizations and the tragedy of this pandemic, if we can bring that to an end and we can keep transmission to a very low level, then I consider the pandemic to be over as a public health emergency. But will this virus disappear? No. That's the reality. I think this virus is here to stay with us, and it will evolve like previous influenza pandemic viruses. It will evolve to become one of the other viruses that affects us. That's the natural history of these things. So and I think that's where the discussion, people say, oh, we're going to eliminate or eradicate the virus. No, we're not. Very, very, very unlikely. What we can eradicate and what we can eliminate is the death, the hospitalizations, the tragedy and the loss, both social, economic and health loss of this pandemic. And we can emerge in a situation where we're fully in control of the virus, not it in control of us. And I don't think we're there yet, Maria. And I think it's going to take many months to come. But I don't, we do have a committee at WHO, the Emergency Committee, that declare when a public health emergency of international concern exists. They have met a number of times in the last year and a half, and they continue to say the public health emergency continues to exist. At some point, we hope, in the coming months, they may meet and say, while the virus is not ended, the public health emergency is ended. And from my perspective, that's when we will say that, not that it's over, but that the public health emergency is over. And it's not over yet. That emergency may seem over in some countries, but in many countries, the public health emergency associated with this virus is far from over.
I mean, not much more to add, but just to emphasize 2 points that Mike just made. I mean, I think we are definitely still in the middle of a pandemic. I know we all want it to be over, and many people are acting like it is over. It is not over. And so everything that you do every day, no matter where you live, whether you're living in an intense transmission area or not, what you do matters. Still working from home if you can, postponing that trip if you can, wearing of a mask, physical distancing, all of that plays a role. Making sure we have good ventilation in the places that we will not only benefit COVID-19, it will benefit other pathogens and other contaminants and air pollution. I mean, all of that is really critically important. But we missed the opportunity to eliminate. We missed that opportunity early on in this pandemic. We had a chance, and I want to be very clear about this. We had a chance in the beginning of this pandemic. I like not to think of the what ifs too much, because it's a very difficult thing for me to think through. This pandemic did not need to be this bad. This circulation of a respiratory pathogen, a novel respiratory pathogen, in a fully susceptible global population, it would have spread. It would have been very, very difficult to contain, but it didn't need to be this bad. Now the question is, what do we do? How do we use the situation that we are in right now to make that change? It's not too late to turn around, to take the death, to take the severe disease and death out of this pandemic. We can do that right now. And we just need to come together. Somebody asked me today, if I could have one wish, what would it be? Or if I could have one ask, what would it be? It's dozens and dozens, but one thing I would ask right now is if we could have all global leaders come together with a common goal. We do not have that. WHO has outlined the global plan about what needs to be done. The elements are there. The tools exist. We do not have global leadership by all national leaders to say, this is what needs to be done. Collectively, this is how we are going to end this. So if I had one wish among many, I mean, one wish is that this virus didn't exist in the first place, but that would be my wish. But I think we need to be very clear about what can and cannot be done. We can take the severe disease and death out of this pandemic. We just need to come collectively together and have that common goal.
Thank you very much to both of you for your time, and I also want to thank all our viewers for really excellent questions today. The list of countries from where you're from is very long, so I'm not going to list it, but I can confidently say from this that we have viewers from all 6 WHO regions, no matter how late or early hours are for them at the moment. So thank you very much for that. Thank you for all your questions, and thank you for following us and our advice. Until next week, stay safe. Thank you.